was received on the 1st of March 2023 with the diagnosis of leukocytosis with hepatosplenomegaly to rule out leukemia. Both the samples show 46XY normal male karyotype. No cytogenetic abnormality detected. Okay. This is the patient report. That's all.
Okay. Alright.
Thank you, Eva. Maybe Diana boleh present the second case.
Okay.
So my second case is Muhammad bin Aiman Hafiz. Problem is hypoplastic MDS, possible of RCC. So he is currently a 5 years 3 months old Malay boy. He initially presented with fever, pallor and bruises in August last year, where he was noted to be pancytopenia. At that time means around 10 months from now. So at that time he was admitted to KPJ Tawakal and was treated as infection, where his coronavirus and Haemophilus influenza was positive. He was given antibiotics and prednisolone for thrombocytopenia, and he had only had bruises but no other bleeding tendencies. And examination showed no lymphadenopathy and no organomegaly. 1 month before this presentation, he also had influenza B infection but was not complicated. So his FVC at that time, HB was 10.7, total white was 4.5, ANC was 0.3, and lymphocyte platelet was 31. The full blood picture done at private center showed pancytopenia with atypical or reactive lymphocytes secondary to underlying viral infection. After he was febrile, parents requested for AY discharge and was given HTA for follow-up. However, they defaulted, but they did repeat his count at nearest local clinic and the platelet showed 41. Only a month later, he presented again with fever, pallor and bruises in HTA KL. At that time also, he had no organomegaly, only bruising. So his FVC at that time, HB was 8.4, total white was 3.2, ANC 0.8 and platelet 15. In view of ruling out leukemia, so the FVC again stand there wasn't any blast. So after antibiotic, counts remained the same, and about a week, bone marrow aspiration and transplant was done on 12 September with platelet cover, and the report at that time was suggestive of aplastic anemia and to look for secondary causes. So we did.
Anna, they presented to HTA tu through clinic
Tak, ED, emergency.
Oh, ED. Okay.
He presented to ED. So Coombs was done was negative. Folate level and B12 was normal. Autoimmune screening in C3C4 was normal. Infective screening was also normal. Serum immunoglobulin IgA IgM was normal with IgG just mildly elevated. So at this time we did think of impression aplastic anemia. So we did HTA typing. He only had one elder sister at that time, so was not matched 6/10. And after that, we did match unrelated donor, which also no match. I put here awaiting with younger sister as the mother just delivered, and currently newborn is only about 3 weeks old. So we wanted to wait for this actual typing with the younger sister. So upon we diagnosed non-severe aplastic anemia, we did counsel for ECG, but parents not keen for the immunosuppressive therapy. So he was just follow up at clinic and also daycare with routine blood. However, he did defaulted in between and was well with no bleeding tendency. He was not transfusion dependent. So on the 8th January, he was admitted for neutropenic sepsis and epistaxis. He presented to ED. At this time, he was transfused with 74 unit and Pactel 1 unit. The family was then agreed for ATG. However, this one is already almost 4-5 months post the last bone marrow. So we counseled for repeat bone marrow aspiration. So the second repeated bone marrow done on 27 February, which is about 7 months first bone marrow, and this time showed hypoplastic MDS RCC. So terms of this child, the different diagnosis from the first and second. And in terms of transmission history, actually he was not transmission dependent initially. His count was always platelet more than 10. However, recently since March, he did require platelet, as the platelet is about 7, about monthly. So the last transfusion platelet was on 11 April. His next TCE is about next week. So he doesn't have significant infection history, only been admitted twice since diagnosis, and his neutrophils is about plus was 1.4. Yeah, that's all for this child. We would like to discuss these two bone marrow SPV.
Yes.
Okay, boleh nampak slide saya ke?
Nampak?
Okay. Assalamualaikum and good evening everyone. I'll be presenting Muhammad bin Aiman Hafi. So the MVP that was done during the first Mero on September 2022, showing HP of 7.6, normochromic normocytic RBC with thrombocytopenia and also severe neutropenia. So it was reported as pancytopenia in Curie course, no blast seen or no abnormal lymphoid cells seen at that point. So bone marrow was done, right and left bone marrow. So as you can see here, the cellularity of both A and left and right was hypocellular for each, and with hypocellular cell trail. Okay. So it's totally different from the cellularity of Dylan Ong. So you can see it's hypocellular marrow, and the cell trail was also hypocellular. Then the erythropoiesis was reduced, and those that present showing megaloblastic maturation as shown in the red circle. The erythroblast was large with nuclear to cytoplasmic asynchrony maturation. You can see that the cytoplasm is mature, however the nucleus still open, a bit immature looking. Granulopoiesis was reduced with all stages of maturation seen. No obvious dysgranulopoiesis noted at this point. There was hardly any megakaryocyte seen during the first bone marrow. Holstein was done and showing adequate stainable iron with no ring sideroblasts detected. So the impression of the bone marrow was hypocellular marrow with reduced erythropoiesis, granulopoiesis, and megakaryopoiesis, highly suggestive of hypoplastic marrow. To exclude secondary causes such as infection, immune-related drug-induced toxin, etc., no evidence of acute leukemia, lymphoma, and non-hematopoietic tumor infiltration. So this was the defined biopsy that was received in September. As you can see, this defined core consists of generally hypocellular marrow with some focal area of cellularity. So mainly the cellularity of bone marrow was less than 5%. However, there is small area consists of about 10% of cellularity. The left side was inadequate for interpretation. So on further magnification, there is some area with less than 5% cellularity, and this is again focal area of cellularity, and you can see there is actually presence of megakaryocyte 1 megakaryocyte here. Okay, on further magnification, there is it shows immature erythroid precursors island which present in island, and also very reduced granulopoiesis. There are occasional granulopoiesis seen in this marrow space. Okay, the erythropoiesis again showing megaloblastic maturation as shown by the blue arrow. It is large in size and also showing elongated nucleoli. So this is megaloblastic erythroid precursors. There are also present of giant metamyelocytes, okay, which shown by the red arrow. Okay, this staining CD235A and E-cadherin highlighting the erythroid precursors and also mature red cell. For example, sorry, the 235A had also highlighted mature red cell, but you can see here there is an island of erythroid precursors and it's large in size, which is megaloblastic maturation. E-cadherin, on the other hand, is staining the most immature form of erythroid precursor. So on HNE, you can see some presence of single megakaryocytes, but when we do CD61, it highlights other megakaryocytes as well. For example, these two megakaryocytes is showing normal nuclear lobulation. Reticulin was not increased. There's no marrow fibrosis. CD117 and CD34 also not increased. There's no increase in immature in blast or any immature myeloblast or B lymphoblast noted. So the defined biopsy was reported as markedly hypocellular marrow with focal area of cellularity composed of erythroid precursors and presence of occasional megakaryocytes. These features are not typical of anaplastic anemia. Relook at bone marrow aspirate morphology done showed erythroid precursor with megaloblastic changes. Granulopoiesis is markedly suppressed. Suggests to investigate secondary causes of IV folate B12 deficiency, parvovirus infection, drug-induced or autoimmune causes. No evidence of acute leukemia, infiltration by lymphoma or non-hematopoietic malignancy. So that was the first marrow and defined biopsy. So repeat marrow was done in February 2023. This is a post-transfusion sample. HP again, moderate anemia. This time, patient has macrocytic RBC. As you can see here, it's ovalo and also macrocytes. Platelet again, severe thrombocytopenia with severe neutropenia. The WBC has recovered, but still the neutropenia is still the neutrophil still severely low. So this is again the right and left side DNA. So the fragment is hypocellular for each, but you can see there is some showing patchy normocellular area. Okay, and the cell train was also hypocellular. So on further magnification, you can see that the cell trail is mainly composed of erythroid series with megaloblastic maturation as shown here. There are features of this erythropoiesis. It is more marked in the second bone marrow. As you can see, there is intercytoplasmic bridging between the erythroid precursors. There are abnormal nuclear budding, bilobated erythroblast. Okay, and then again, there's a very marked intercytoplasmic bridging between these two erythroid precursors. Okay.
What's the significance of bridging, Alin?
Very significant, Dr. Zhu. Sangat
What does
significant.
it indicate?
This erythropoiesis in this patient.
Oh, this
This erythropoiesis lah, which was not present during the first marrow. And then the granulopoiesis, this it's mildly reduced, but with all stages of maturation. But we can observe there is actually features of dysplasia, this granulopoiesis, for example, this abnormal nuclear lobulation and also pseudopelgia neutrophil. You can also see more of megaloblastoid changes in RBC and also abnormal nuclear lobulation in the erythroid precursors here.
abnormal what?
Abnormal nuclear lobulation in the erythroid precursors here. Okay. This one, Dr. Zhu. Okay. So megakaryopoiesis was reduced, but upon further magnification, noted that there is micromegakaryocytes and also monolevated megakaryocytes. So there is actually these plastic features in significant percentage of all cell lines, erythropoiesis, granulopoiesis, and also megakaryopoiesis in the second bone marrow.
What's the time from first to second? 5 months.
5 months, yeah, about 5 months. Okay, and then the person again as adequate standable iron with no ring sideroblasts noted. So reported, the bone marrow was reported as hypocellular marrow with triadysplasia, consistent with hypoplastic myelodysplastic syndrome, refractory cytopenia of childhood. Please correlate with cytogenetic results. Other acquired or secondary causes of myelodysplasia need to be excluded. Sekejap ya, Dr. Zul. Oh, Dr. Mimi tak dapat masuk sekejap.
Because so my next question is that some kind of progression for MDS from aplastic become
Ada different, there are features that we can differentiate between those two. Nanti I share in the last slide, Dr. Zul. Sekejap ya.
even on the first slide. Can you differentiate between aplastic dengan MDS on your first marrow?
Quite difficult nak differentiate because from the first case tu, the marrow cellularity tu macam sekejap the marrow cellularity tu kita boleh nampak a bit there are orang kata patchy hypoplasia kan. So usually in a plastic you don't see this focal of cellularity. Usually semua akan less than 5% macam ni.
So from the first marrow already you suspect that it's not bukan of aplastic lah.
Ya, sebab tu kita kata hypoplastic rather than dah plastic masa tu. Okay, saya pergi ke the second treatment again. Sorry Dr. Mimi sebenarnya tadi dia nak minta join tapi I yang moderator so dia baru je join. Okay, so now we go to the treatment biopsy of the second marrow Zul. So as you can see, this time again there ada patchy hypoplastic marrow, but there are more of less than 5% cellularity. Only very limited focal area of cellularity, macam ada 2 points saja dekat sini. So comparatively it is reduced from previous bone marrow, the cellularity this time. Okay, on further magnification, again we can still see erythroid precursor forming erythroid islands around this area. Megakaryocytes were reduced. I suspect this is again another megakaryocytes which is abnormal. However, I attempted CD61 to really see this megakaryocyte population, but there were tissue loss. It was inconclusive for interpretation. But CD235A, you can pick up again this erythroid island, which consists of mainly immature erythroid precursor, more than 10 cells per focal area. This is again E-cadherin. Okay, reticulin also not increased. So conclusion for the second marrow correlating with presence of trilemnic dysplasia in the bone marrow aspirate, this treatment biopsy support the diagnosis of hypoplastic myeloplastic syndrome or refractory cytopenia of childhood. Okay, and then this is actually found in WHO classification book. The red box actually consists of typical bone marrow findings in the plastic anemia and also in refractory cytopenia of childhood. If you can see here, aplastic anemia usually they are the absent or very few cells without dysplasia or megaloblastic change. But in our patient, we have erythropoiesis with nuclear segmentation, multinuclearity, and also megaloblastic changes. In aplastic anemia, there shouldn't be any dysplasia in all cell lines. But in our patient, we see pseudoplagioclase, micromegakaryocytes, and also small round nuclei megakaryocytes. And in trephine, in aplastic anemia, usually there is absent or only single small focus, usually consists of less than 10 cells of erythroid series, and usually dah mature lah. But in our patient, we have more than 10 cells per focal, and also there are left shift and patchy distribution. Granulopoiesis in aplastic anemia usually absent or markedly decreased. But in our patient, we have it's still present and a bit of left shift. And megakaryopoiesis in aplastic anemia, there shouldn't be any megakaryocytes seen, or if other pun very few and no dysplastic features. But in our patient, we have dysplastic changes and also micromegakaryocytes. So both aplastic anemia and RCC shouldn't have increase in CD34 or CD117 precursor cell. So that's why, as a conclusion, we we conclude that this is actually hypoplastic MDS, refractory cytopenia of childhood. And I think the cytogenetic pun ada findings juga. Maybe we can get Dr. Eva to present the cytogenetic.
Betul. Nak tanya, then why kita masa first BMA dengan second BMA tu, maksudnya first tu bukan plastic anemia lah.
Dia tak fully aplastic, dia hypoplastic because ada focal area, but the features of dysplasia tu tak
nampak masa first one.
during the first marrow.
But I think your first marrow pun you dah comment lah, it's not typical.
Not typical, yeah.
Yes.
It's not typical, so we thought initially it was secondary causes of plastic anemia. But it was non-severe plastic anemia lah. So enough we reported the bone marrow before we proceed with immunosuppressive therapy. Discuss betul.
Adakah because of the treatment dia punya counts tu macam recover, the celerity tu improve, but the dysplasia tu dah more prominent compared to the previous one.
Yeah, I think Liana, sebab your atypical tu you maksudkan the secondary causes is not so.
Okay.
The plastic anemia is not a classical of aplastic, whatever the cause is.
Alright. Okay, faham.
Right, now we proceed with the cytogenetic for the patient Muhammad bin Aiman Hafi. So we received 2 bone marrow sample. MR907/22 was received on 12 of September 2022 with the diagnosis of pancytopenia to rule out aplastic anemia or hematological malignancy. The result is normal, 46XY in 15 cell examined. This is the karyotype of the patient and the report. There's no cytogenetic abnormality detected in the first bone marrow sample. For the second bone marrow sample, MR22/23 was received on 27th of February 2023 with a diagnosis of to rule out leukemia. So we get a mixture of normal and abnormal cell. The normal cell consists of 46XY in 26 cell examined. This is a normal karyotype. And the 4 remaining cells show near tetraploidy with extra chromosome X, chromosome 8, 14 and 16, and also there's loss of chromosome Y, 13, 15, 18 and 19. This is in a composite karyotype pattern. This is another karyotype. So for this one, this cytogenetic abnormality has not been specifically associated with a particular hematological disease, but it does indicate the presence of a chronic disorder. So the prognosis significance of this study could not be defined.
So chronic disorder means aplastic is out lah.
The cytogenetic anomaly doesn't point to what type of hematological malignancy. Just indicate there's a clonal clone is present there lah.
Chronic disorder. So myelodysplastic is under chronic disorder ke? Myelodysplastic is under chronic disorder, hypoplastic?
Yeah, it's under chronic disorder, but then this one is not specific.
Yalah. But it's confirmed. But aplastic is not considered chronic disorder, right?
Aplastic tak ada.
So this point towards the MDS lah. It's evident. But it's funny when the first marrow tak dapat. It's a part of the progression ke apa lah. Because it's all the second marrow is like a progression of the disease showing its true picture lah, kan?
Macam evolution daripada first marrow tu.
Evolution. So kalau if we jump into the treatment as plastic then if parents are agreeable, why not respond, right?
Kalau tengok cytogenetic ni kan Dr. Zul, it's very complex cytogenetic. So complex. Yeah. And then the morphology tu memang dysplastic lah. It's this mark.
Because if you let's say in other cases, if you mentioned there, it's not classical for aplastic anemia. What's our next thing? Of course, you look for the genetic or cytogenetic ke
Maksud Dr. Zul apa tu Dr. Zul? Maksudnya the cytogenetic
picture, let's say
factor.
case ni, because it doesn't show a true picture at first presentations, where our mind is been thinking of aplastic, but when we did marrow, there are features who didn't suggest aplastic. Should we repeat marrow, wait and see, and
Kalau dalam kes ni, because yang marrow ni, masa the first marrow tu, I actually look at the, I didn't show me the T5. So the marrow tu kita macam relook sekali lah. The dysplasia is there but not marked. But the features of the T5 tu memang tak boleh nak masuk dengan aplastic. So we say okay, maybe this is the reactive changes ke, is too early to say. So kita kata we just report that it's not typical of aplastic, maybe to monitor dulu lah. So and then the treatment, selalunya you all will not go for aplastic treatment kan kalau kita bagi report macam tu. And then maybe you will do some, you will investigate for secondary causes and then treat supportive. Tapi kalau tak ada improvement, then most likely it's going towards either is RCC lah. But the second marrow tu memang mark lah changes dia, and then supported by the cytogenetic of the complex cytogenetic findings that you do not see this in aplastic anemia.
your MDS kan banyak classifications kan?
MDS is part of clonal disorder. I don't think aplastic is clonal. I do not know
That's fine. Within MDS, this is the one that you have seen ring sideroblast, one of the types.
Correct. Tapi dalam kita punya marrow, kita rasa tak ada ring sideroblast kan ni?
Ada.
Tak ada ring sideroblast.
Dia sepatutnya ada more than 15% ring sideroblast, ring RCC kan ni? Kalau yang with ring sideroblast.
Ring sideroblast.
Ada nanti tak classification soal MDS tu kat sini?
Ada tapi ada tak share kat dalam presentation.
Kita boleh share dalam WhatsApp nanti.
Boleh.
Among the prognosis, among the MDS, is this the good one or bad one?
Kalau hypoplastic MDS, RCC ni Dr. Zul? Alamak, tak pernah pula nak ambil attention dari
Actually, because the type does indicate some prognostic features kan, prognostic.
Bukan apa nama ni, prognostication of MDS bergantung juga sama. I do not know for the pediatric lah, kalau macam dark tu dia ikut IPS score kan.
Ya.
They still refer to the blast count lah. Kalau macam blast more than 10 or then it's already apa tu. Kalau adult punya version it will be MDS with excess of blast type 2. Kalau 5 to 10 masih lagi type 1.
Kalau dalam buku ratio ni dia kata karyotype is the most important factor predicting progression to advanced MDS. Patient with monosomy 7 have a significantly higher probability of progression than do patients with other chromosomal abnormalities or a normal karyotype.
I just want to add in, I'm Dr. Chin here. Regarding the cytogenetics, I think the first cytogenetic sample that you sent to us, I think that time the cells were very little, so we only managed to analyze about 15 cells. So there is still a possibility we did not manage to capture any of the clonal cells. However, the second sample that we received this year in February, the cells was a bit better with a bit more cells, so that's why we managed to capture the clonal cells in terms of the aneuploidy. And it is known that in RCC that about 70 to 80% they may have no abnormal karyotype. and they do have abnormal karyotype. One of the significant finding would be monosomy 7, which would carry a poorer prognosis.
But this one don't have
Cytogenetic check, do you have any having the investigation mention about the complex cytogenetic which we see in this patient?
In children, there's no specific cytogenetic prognostic factor like the adults. Like in adults, there's the IPSFR. But in children, generally, there's no specific prognostic stratification that is applied. Because in children, it's more common to have monosomy 7 rather than 5q deletion. As compared to adults, you will have more of a 5q deletion.
It's just that usually I do not see macam staring dysplasia dalam pediatric punya hypoplastic MDS that we've diagnosed before. But this case ni dia memang the second marrow tu
Semalam center tutup gila. Semalam center tutup gila. Semua infeksi datang hari ni. Dia nak buat kerja SQ je. Boleh ni kan dia datang hari. Apa tu? Aku tu tak pasang buat tu. Aku follow.
Next.
Okey, kat bawah tu tadi. Satu tu. Kau tengok bawah.
Dana, any question? You have any question, Dana?
Ada apa ni?
This patient is different to HTA typing the younger sister lah. But the father only approved during yang younger sister umur dia 2 bulan. So for now,
2 bulan?
2 bulan, ya.
Umur 2 bulan, ambil darah je kot.
Ya, doktor dah cakap dah. Because if the younger sister match, this one I tanya Dr. Ida tadi lah. If younger sister match, then for younger sister lah.
But how frequent is the blood product requirement
For
for
now, since March, dia macam perlu monthly untuk keep the platelet.
because the platelet is very low.
Yeah. Actually, we did give TCA 2 weeks lah. Tapi dia tak.
Can you run the father with regards to complications of bleeding?
Yeah,
Before it's too late.
Yes, I did. We did. I mean, dah banyak kali bagi tahu parents juga. And then when we TCA also we
Bagi darah anak tu kan.
Yeah. Because this one memang orang compliant to TCA lah.
Azmi ke apa tak?
So we
What's
hope.
the parents' social background?
Mother not working, the father is working as a technician. But he had like insurance going to private before that.
Oh yes. Their insurance.
Yeah.
Back lah sebab 5 tahun kan. Apa kan sebab dalam tu.
With the last in,
So 2 months will be next month lah, the baby.
yeah. Next month baru boleh ambil. I wanted to get this month, but dia cakap nak tunggu besar 2 bulan. At least he agreed because we know from the start ada banyak restriction kan. Discuss dengan parents.
Pusing aku.
Yeah. Right from the beginning.
IPR dia diagnose dia. Memang lagi lah tak boleh. Nak overall faham tak? Dia kata, doktor kat sana kata kalau nak makan. Kalau tak boleh cik. Aku expect kat dia.
Muhammad.
Kalau itu dia SNZ je kan?
Muhammad Ashraf Haikal bin Muhammad Amir. Our issues is by cytopenia, the anemia and history of neutropenia, diagnostic dilemma, whether this child is having Southeast Asian ovulocytosis with concurrent hemoglobin nephropathy. First of all, this patient is 10 years old Malay boy. He actually from Kedah, Alustar. He was referred from Hospital Sena Bahaya for cytopenia in February this year. So reason he doesn't want to go to Penang as there wasn't any family members there. Instead in KL they have nearby living in Sungai Buloh. So he is the eldest from 2 siblings. Father is 37 years old, having own business. Mom is 31 years old, housewife. So back history in October 2022, he was noted pale and first presented to Hospital Sena Bahaya with HP of 5.7. At that time, there wasn't any fever, no bruises, no bleeding tendency. Examination, there wasn't any lymphadenopathy, no organomegaly. The workup for causes of anemia, red tip was only 1.1%, home test was negative, total bilirubin was 32, LDH was 202, and uric acid 314. Extensively workup for autoimmune workup and infective workup doesn't show any positive findings, and basicity was normal, and polyp was also normal, iron status was also normal. So the full blood picture showed severe anemia, throat blood loss hemolysis with underlying iron deficiency anemia, and HTA ovalocytosis. HB analysis was also done prior transfusion and showed slightly increased HbF level for age, possible due to acquired cause with HTA ovalocytosis. So just to show the progress of this patient, so on 30th October, HB was 5.7, was transfused Paxil, and the FBP showed SAO, and there wasn't any organomegaly. So he was given 2 weeks, 2 weeks CCA after that in the same hospital, and that time showed HB 6.1. Other counts was normal. At this time, they already consulted hematology oncology team Penang and was suggested to counsel for bone marrow aspiration refine, but they refused and subsequently defaulted. He was not transfused at this time. So he only presented again about 2 months from presentation, or 2 months from this HB 6.1 with symptomatic anemia, and this time HB was 3.9, total 2.9, headache 238, and C1. And this time was transfused Paxil, and HB was 9.2 on discharge. So was given PCA 2 weeks from the last transfusion. HB was 6.9 and was again transfused Paxil. This time the family agreed for bone marrow PMAP and was then transferred to HTA. So all this while from October to January, he was transfused 3 times. So 1 week after presentation, he was transferred to HTA. At this time, on our examination, he had liver 3 centimeter. Otherwise, no dysmorphic features, no other complaints. So his FBC was total at 3.7, NC 0.9, HB was 9.2, platelet was 174. So bone marrow aspiration and treatment was done at this time. And he doesn't require any blood product transfusion during his admission for about 2 to 3 days here. So we see back him in our daycare in 1 month time. His HB was 8.3, platelet was 196, total white was 4.7, and NC was 2. So at this time, the issues was only anemia. So we did give another PCA in April, but he did not turn up. However, upon we called him, he was well and he did not presented to hospital Bahia for any symptomatic anemia. But he will come this week by Friday.
But the HB didn't drop that much, right?
Yeah, after this one.
Yeah, it's like
only the first initial part. So bilateral BMA that was done during his admission here on the 8th February showed hypocellular marrow for age, lineage, dysphagia, and pure hemophagocytosis. Considered acquired causes of marrow dysphagia and hemophagocytosis. Exclude parvovirus causing worsening in SCA or with refractory cytopenia. And Trefine showed marrow changes secondary to SAO with concurrent inheritance thalassemia. Differential diagnosis was congenital erythropoietic anemia type 1. BMA cytogenetics was normal. We did send B12 and folate again, which showed normal range. Iron studies was also normal, and parvovirus again was negative. Due to this finding and previous history mentioned there wasn't any screening of the parents, so we did screen the both parents, where the father FBP showed hypotonic microcytic anemia with high RBC count, with suggestive of thalassemia or hemoglobinopathy, and mother had SAO. So this case I discussed with Dr. Susanna, so we plan to send further investigation this Friday, where we would like to send the both parents HB analysis and DNA analysis with molecular analysis for SAO, and patient for DNA analysis and molecular analysis for SAO. So we would like to discuss the marrow finding and identification, including the parent finding.
Hospital Sultanah Bayang ada buat ni molecular for SAO.
Yeah, this one Dr. Susanna baru mention. They agreed, they said can do.
Kita tak payah hantar bertam lagi ya, Susanna?
Ya,
Tapi dia ada syarat-syarat dulu kan?
Ya.
Present dulu. Okey, saya present dulu ya.
Okay.
Boleh nampak ke? Alright, so
So this is the first FPP that we received when the procedure of marrow procedure was done back in February. So he had moderate anemia, HP of 9.2, but this was roughly about 1 to 2 weeks post-transfusion sample. Based on the red cell indices, it is normochromic normocytic. Patient has leukopenia with moderate neutropenia and borderline low normal platelet count. So if we look under the low power, there is actually ovalocytosis, although this is actually in a post-transfusion sample of this patient. Okay, close up higher power of the FPP. So we do see moderate anemia with background of ovalostomatocytosis. So these are the stomatocytes, the slit mouth appearance on the red cells, and on top of that there is leukopenia and moderate neutropenia. So marrow procedure done bilaterally, right and left. It was a very good sample, good number of fragments, and the fragments are generally slightly hypercellular for age. I just captured 3 photos of the fragments, but there are a lot that we get on the slides. So under the cell trails assessment, it is a good cellularity, and we do see all the 3 main hemolytic lineages, the erythroid, granulopoiesis, and megakaryocytes, which are not present in this photo, but I have another picture to show you. Okay, so assessment of the erythroid cells, there are erythroid hyperplasia, increase in the erythroid series. All these are his erythroid cells. And there is this erythropoiesis. There is ragged cytoplasm, binucleation, megaloblastic appearance, again, ragged cytoplasm, intercytoplasmic bridging, binucleation. Since there are also some granulocytic cells in here, I just want to highlight that they are present in all stages of maturation, the promyelocyte, myelocytes, meta, perhaps these are the bands and the neutrophils, the mature neutrophils, which are of normal morphology with no significant dysplasia seen on the granulocytic series. This is another close-up, high magnification, high power of to show the increase in the erythroid cells and the megaloblastic appearance, as well as the dysplasia on the erythroid cells. Okay, as mentioned, granulocytic series are preserved, all stages are seen, and there is no evidence of dysplasia on the gran series. Okay, this is the megakaryocytes on the bone marrow aspirates. In terms of the quantity, they are adequate in number, but we do see occasional megakaryocytes with evidence of dysplasia, like abnormal nuclear segmentation, widely separated nuclear segments, and hypolobated megakaryocytes. Other than that, we also notice that there is increased number of macrophages. So these are some of the examples of the macrophage. Mostly are either empty or they contain dead cells or cellular debris, but occasionally we do see some with hemophagocytic activity. Okay, and this is pearl stain where there is marked increase in iron store, and there is no red sideroblast seen on this slide. A bit of iron contamination on this smear, but there is no red sideroblast observed on the slides. So at this point of time, we concluded the bone marrow as hypercellular marrow for age, bilineage dysplasia, and evidence of hemophagocytosis. We would like to consider acquired causes of marrow dysplasia and hemophagocytosis, such as infection and metabolic disorders, because at this point of time, most are already screened and negative by the HSV team. We suggest to exclude parvovirus infection. Serology was not done at the time when the marrow procedure was performed. And if there is, it could may actually worsen the cytopenia in the background of Southeast Asia ovalocytosis in this patient. We put our differential diagnosis as RCC once acquired causes have been excluded, while we wait for the bone marrow cytogenetic findings report to come back.
So this was the refined biopsy for that particular procedures in February. So we get right and left, but the reporting was performed and assessment was performed only on the right side. It was roughly about 18 mm, very good sample, I think about 8 to 10 narrow spaces. But on the left side was suboptimal, was inadequate. So marrow was hypercellular for age. And when we scrutinize and assess on the narrow spaces, there are actually evidence of erythroid hyperplasia. Megakaryocytes are present, quite normal looking megakaryocytes, mostly adequate in number, and we do see all the granulocytic series at all stages of maturation. But other than that, what we noticed initially when we have a look for the H&E, we noticed these mononuclear, slightly immature looking cells that is appear loosely in clusters together. So we were initially worried whether this could be an abnormal localization of immature precursor ellipse, which is also one features of dysplasia in marrow. So we did further stain to confirm what are those immature mononuclear cells and not partners. So we did order for CD34 and CD117. IHC slides came back as just scattered positivity on 47 and clearly negative on CD34. So conclusion from this IHC stain is there is no excessoplast and no abnormal localization of immature precursors. So what are those cells? On further stain, we do for cadherin and CD32-35A, they are actually erythroid series, especially in the pro-erythroblast, the early stage of ERI, as well as the mature ERI. So those cells that we saw is actually belongs to erythroid series. And on CD61, they are singly scattered, quite normal looking on refined biopsy of these megakaryocytes. And this is the reticulin stain, which showed no increase in the reticulin fibers rate 0 to 1. So as mentioned by Dr. Liana, hemoglobin was fairly acceptable for compared to his previous baseline and story. So it's a moderate anemia. Somehow the ANC has recovered this time, and patient has not been requiring any transfusion from the last admission in January 2022. So I actually managed to capture the FPP of the father. So very titrate, mild anemia, very high RBC count, hypochromic microcytic cells, and the WBC and platelet is okay, unremarkable. So we can see it is a hypochromic microcytic picture with presence of target cells, teardrops, pencil cells, and occasional teardrop cells. Yeah, this is the FPP of the father. So very titrate picture. And this is the FPP of the mother, which is normal HB. MCV, MCH is slightly at the low range, borderline low normal, with normal WBC and platelet count. And there is ovalostomatocytosis in the mother. This is the close-up view, very obvious ovalostomatosis. So I rang up pathologists at Hospital Sultanah Bahia Kedah just to check if there is any record of investigations done in Kedah for parents. So as for the father, there isn't any record, but as for the mother, she had one HB analysis done in March 2013. Patient was maybe around 22-year-old, I guess, during the pregnancy of this child. So there was one HB analysis done, which was normal, but there is no record of any DNA analysis for thalassemia. And as for the patient's HB analysis, as shared by Dr. Liana just now, there is one HB analysis which showed mildly increased hemoglobin F, which they asked to consider acquired causes, and they actually comment KIV to repeat HB analysis later. On top of that, of course, the sound that is also present on the sample. So actually, when we review the refined biopsy, we actually review the bone marrow aspirate and FPP slides again, and also we review the latest investigation results that came back to make the assessment of this refined biopsy. So this is our conclusion. Basically, it is a hypercellular marrow with erythroid hyperplasia and erythropoiesis. and there is morphology of Southeast Asian ovinocytosis. So our differential diagnosis for the above features that is present in this patient, number one is marrow changes secondary to hemolytic disease of Southeast Asian ovinocytosis. Especially with the father that has thalassemia indicis and the mother who has SAO, we would like to suggest to exclude concurrent inheritance of these both red cell disorders. So actually, when we look at the literature, combination or co-inheritance of these two, thalassemia and SAO, mostly are just a single case report that is published. So they are usually hypochromic, they are usually mild anemia, mild to moderate anemia. But this erythropoiesis is a feature that can be seen especially in homozygous SAO together with erythroid hyperplasia, but I do find few people also mention that it can also be present even in heterozygous Southeast Asia ovinocytosis, the dyserythropoiesis. The next differential diagnosis that we could think of with this morphology is actually congenital dyserythropoietic anemia. Although the bone marrow cytogenetic impact is as normal, refractory cytopenia of childhood is not completely can be excluded, but we think it is less likely in these differentialists because of the cytogenetic findings and because of the spontaneous recovery of his neutrophil count. So this is what we suggest, HB analysis of parents. They will be coming back this Friday, so please send to us. DNA analysis of patients and parents, we will do for both alpha and beta. And molecular analysis for SAO for this patient and parents. So actually SAO ni, Dr. Hafizah in Hospital Sultan Al-Baqiyah has already optimized the method. It was just recently that she agreed to start accepting cases. But it has to be case-to-case basis that we have to consult and discuss with her when we have any case to send to her. If let's say for any issues they will liaise with Bertam, IPPT Bertam in case if they need further technical or further things to consult with the more dengan lab yang dah sedia offer the test lah. So yeah, I think that is all.
Susanna, you mentioned just now the possibility of thalassemia and Southeast Asia.
Yeah.
See, common
Ada lah kalau kita baca there are some case report especially in Thailand mentioned about this.
So that dysplastic erythroid contributed by SAO.
Southeast Asia, yes. The dysplasia, this erythropoiesis can be a feature seen in heterozygous SAO as well as definitely homozygous SAO in more marked heterozygous.
Kalau tradisi
This one is like hetero, is it? Heterozygous?
Macam mana?
You have the parents. This one doesn't look that bad, isn't it?
Yes. Like the mother kan very normal HP. Usually heterozygous will be like this or at most mild anemia.
Tapi kan Dr. Zul, kalau thalassemia, kalau kita report thalassemia, memang kita akan look for SAO. Sebab apa? In thalassemia, if we have SAO, dia punya membrane integrity of the red cells tu dia lagi cepatlah nak pecah. So you can have some degree of anemia. Tapi dalam kes ni, kita tak rasa thalassemia is the main issue. We were thinking whether this is actually SAO yang maybe both genes from parents are affected, tapi mungkin tak. We do not know lah macam mana start kat mana genes tu affected. Macam kalau katakan kita buat beta pun kan ada beta plus. So SAO pun we were thinking in that line. It's not straightforward. Homozygous SAO, because homozygous SAO usually not homozygous.
But the retic is not increased, eh?
Sorry?
The retic count is not increased. The retic count dia normal kan? Low.
Yes, normal.
Sorry, mencelah lagi. Tapi kalau punya time dah nak habis lagi 5 minutes. Boleh kita masuk room baru ke macam mana?
Ada lagi kena discuss?
Dalam
room baru lah, Ali.
Baru kan?
Masuk yang baru boleh Dr. Zul?
Satu genetik kita tak tengok lagi kan?
Satu genetik belum lagi. Soalnya ada share link dekat messages tu. Minta maaf next time kita guna yang lama sikit. Kita masuk grup yang link yang baru tu.
Okay. Alin dah post ya?
Dah post dalam message.
Yang 5-15 ni? Yang 15 ni?
Betul.
Okay. Hello? Ya, salam. Okay. Kenapa? Itu better lah. Dia buat CT scan. Kena buatlah CT scan. Tak ada beli. Okay. Tak ada bleeding lah. 27 that was how many days ago? 5 hari lepas. Tak ada bleeding. Masa tu dia tak bleed betul. Oh. So probably not necessary to repeat lah. You trying to repeat tak ya? Probably that lah. I thought you tak buat lagi ni. Never mind. Okay.
Itu anak gila.
Your FFP.
Saya nak bawa anak saya dulu. Kali pas. Bawa anak, semua bawa anak.
Yang balik apa? Tak ada pergi tu? Bagilah. Bolehlah finish that tu 1:15 lah. Tapi you tengok sekitar ke overload dia nak reduce start lessons ke apa, provided the BP is okay lah. Memang kena continue. Dia ada thrombosis kan? Yes, I think better BD lah. Berapa? Tak ada BD. Sebab dia better because sekarang the dose kan tapi the suction dose will be based on the level of antibody. Itu last kali advance dan berapa